think you just have to
start. And when I need to be there, I need to be there.
Okay. That extra.
It's okay. It's okay. Yeah. I understand that. It's fine if it doesn't happen. I was just like, no.
Okay, we're going to go ahead and get started. Joan, did you just do this part? I thought I did. Okay, we're going to go ahead and get started. Is everybody still awake out there this morning? Have enough coffee? Okay, so our next segment is we're going to talk about confidentiality. As you all know, that's a really big, important process that we follow when we're taking care of our patients. You know, and sometimes it's challenging. So we're just going to go through the things that we feel are really significant to touch on. We're going to do a little exercise, and then hopefully we could open it up to some questions. So how do you feel if someone would betray your confidence? Let me just shout out a couple things. Like, how does people feel if someone that you trust in particularly betrays your confidence? So none of us really like that. If we say to someone, you know, I'm telling you something and I hope you keep it in confidence, and then you find someone doesn't do that, You feel that that person really violated your trust. So in this exercise, we're really going to go through 3 reasons for maintaining confidentiality of a client's personal information. We're going to go through a script. We're going to go through some checklists. And we're going to just see where the discussion leads us, okay? I did this presentation in 2013 when we did our R18 Enhancing the Use of Hydroxyurea study. And when I went back to review it, I really found that not much had changed. I don't know if that's a good thing or I don't know if that's a bad thing. So maybe that's some dialogue that we can have afterwards. Think about it. This is about a 6 or 7-year-old presentation, yet most of the information, in my opinion, seemed like it was still relevant. So obviously, your patients really appreciate you protecting some of the things they say in confidence. And I know sometimes with our team, there's even a struggle amongst ourselves sometimes if we should share some pertinent information with the other team members because someone says that they told them something in confidence. What's your opinion about that? If a patient navigator, for example, is told something in confidence, should they be telling the other team members that they're working with on that patient, what that patient shared with them? Why would you think it's not important for them to share that?
It depends on what was shared.
Okay. So let's say somebody shared something about a personal violation to themselves. Okay. Let's say they shared something about how they feel about another staff person that's on the team. So if a patient comes back and says to somebody, I don't really like working with that person should keep that to themselves and not share that with the person that they're working with?
I think it's important for the navigator to talk to that patient about, how do you feel about me sharing that? Would you like to share that? Would you like me to be present while you share that? Would you like me to be your voice in that? Talk through the options for making sure that you can kind of unpack that so that things can improve.
And I want to say people do that professionally, but what happens if that person tells them no? Okay.
If the patient tells the provider that they do not wish to work through the steps,
Yes.
then if it's not affecting care, I don't think that information needs to be disclosed.
If it is affecting care, then what do you do?
If it's affecting care and they don't want to go through the steps of talking to the other provider.
And I'm asking this because this has come up in our own department. So I want some feedback about this because I have had my opinions and I want to just see if I was right or wrong, whatever, either one. Okay, let's get the microphone then because I think this is really important discussion. Because when you're working as a team, you come across these circumstances, whether there's personality differences or there's practice differences or cultural differences. I want to get some feedback about what you all think a team should do when there's a person in the team that knows something that someone else does not know. Okay, so let's start with Kelly back there. Kelly, I saw your hand raised. Or Kelly? It's Kelly. Keely, sorry. I knew it was spelled differently. I just was pronouncing it Kelly.
Hello. I was just going to say, in my role as a social worker, I think something I try to keep in mind is the patient telling me this as, you know, they just want to vent about it, they just want to express their feelings, they want to chat about it, they want someone to hear them, or they actually wanting me to do something about this, or are they wanting to do something about it? Maybe they just want to vent and express their frustration. And it's not my place to step in and tell them that they have to do something about that. On the other side of the coin, if they're expressing it to me and they're saying, I refuse to see that provider, or this needs to change, or something, then I think, to Ray's point, then it's more of a dialogue of, okay, what do we want to do about that? How do we want to address this? What are you comfortable with, and how can I help? fix that?
So the provider piece is really interesting. I think it's a little bit different than the rest of the team because sometimes our patients don't want to see certain providers who may not give them what they want. So we've actually set up a practice that we really, unless there's really a specific reason that, we would need to evaluate as a team, we feel that all of our providers should be open to all of our patients. Because first of all, something could happen to that other provider. It's also good for us to have providers who have cross information on patients so that when they're on call, for example, if John Smith calls the 9800 number over the weekend and has been a patient for 2 years, but Dr. Smith has never seen him, and maybe he's somebody that we don't talk about frequently, maybe Dr. Smith's really not going to know how to respond to this call, and it's more of an urgent matter just because he doesn't know the patient. So we're really trying to not allow patients to make those valid choices for the reasons that we think they may want to. So if they think so-and-so is going to write them a script and other doctor's not going to do that, we're going to say, no, I'm sorry, this is the appointment that's available, this is who you need to see. But sometimes patients do like to have certain relationships with people, and we do respect that. But if there's an issue, like Dr. Smith goes out of town and there's someone on his schedule, but Caitlin's available, we're not going to cancel that patient's appointment. He or she may just have to see Caitlin for that particular visit. So we do try to be very cautious about that. Yes?
Do you think that when,
Oh, hold on one second. The recording does not get your voices without the microphone. Yeah.
do you think that when patients express something like that, that they may need, sometimes it is something that they have already put their finger on as to why they didn't. Sometimes it's a feeling. Sometimes there's lots of different reasons. And I'm not always convinced that just because the day you share it with me, you're not willing to confront it, doesn't mean that the next time that we talk about, like if it's an ongoing issue, maybe it's just a one-time issue. I also think that the navigator should be helping that patient to kind of unpack those feelings and put some things in context for that patient so that it gives them a chance to walk away and think about and process, because in the moment, those emotions that they're feeling are less likely to change permanently in that moment. Many of our patients often just need time to process what you're telling them. And then maybe you pick up with it the next visit, and so that it doesn't just fall by the wayside or get pushed to the back burner. But I think that sometimes we can be too quick to bring it back to the team, which in some cases, and I don't know the dynamics of your clinic, but in my clinic particularly, sometimes that can create biases that are unnecessary.
So we've had all of those things happen. Everything everybody has said here has been things that we have been challenged to do as a team, and we work through it. Sometimes there's not the right answer, but it's really important to try to just keep an open dialogue. I think all of our staff are well trained enough that they do try to do all the things you suggested, and sometimes it just doesn't work, and we have to figure out whether or not we need to share that with the team. But you're absolutely correct. So I do think that for the role of the health navigator, oh, I'm sorry, go right ahead.
That's okay. I was going to say another thing that's really important for anyone who's kind of in that position between kind of the liaison between providers and patients. It's important for us to have an ear to the ground to look out for patterns of our providers. So I think that sometimes it is necessary for us to communicate. If a patient says, no, I don't want to talk about that, I don't want to bring it up, it's important for us to be able to say, okay, I hear this one patient, but this patient also has an issue with the same provider. This patient has an issue with this provider. This patient has an issue with this provider. Maybe it's something that the provider needs to know. And it's not saying, hey, this patient, and this patient don't like you. It's, hey, I'm hearing some consistent concerns, and me as a liaison, me as somebody who can be that middle person, thinks that I need to bring this to your attention because maybe it is the provider who is acting in a way that the patients can't speak up for themselves.
And that's very true as well.
And so it is important for us to bring those points up at an appropriate time.
Thank you for your feedback. So I do feel as health navigators, you probably do hear more complaints than anybody else does within the team. And so, I think it's just sometimes important to bounce that off of maybe your supervisor if nobody else. just to make sure that you are making the right decision and that, you're not taking on some kind of ownership of something that maybe, you just need to make sure someone else is in agreement with you on. So obviously confidentiality is the responsibility for protecting private matters from unauthorized disclosure. I always find it very ironic when you go into a doctor's office and they have you sign these privacy, HIPAA things, and then they yell your name out in the waiting room. I'm kind of like, doesn't that kind of defeat the purpose? But if my husband calls you, you can't talk to him without my permission. So I think that's really interesting. Privacy, the right of the individual is, of course, to be left alone. And sometimes that's hard for us as well to, respect that. And security, of course, means to control access and protect information from accidental or intentional disclosures. So in, 1996, what I was just talking about came into practice, which was the Health Insurance Portability and Accountability Act. And anytime you go somewhere, you have to give permission, even for your spouse or your significant other, to be able to have, the ability to pick up your medications or to get any information about your medical condition, or, just for whatever reason, they can't talk about you in front of everybody else in the waiting room. But again, I always have kind of a little laugh about that when, oh, Shirley, Shirley Johnson, are you here? It's like, oh yeah, I'm so glad I just signed that HIPAA Act. So also part 2 is the Public Health Service Act, which we'll get into a little bit later, and the Family Educational Rights and Privacy Act. So what I did is I put just a very small story in front of you. I would like you to just take a moment, read the story, kind of put down some feelings and thoughts about what you think is your responsibilities and options you have in dealing with situations like this. And then we're just going to have a brief discussion. Joan went somewhere. I don't know where she went. Oh, there she is. And she's going to write some of our answers down on the sheet up here. So just take a few minutes. Read. Did you get the stories, everybody? Joan, you didn't hand them out to everybody? Anybody else on that one? Anybody else? Okay, did everybody have a few minutes to write down some thoughts? Okay, Joan, you need to get your microphone.
Yes.
And how about, if we can, try to shout out, but if not, we need to at least get the microphone for some of the answers. So who would like to give some ideas about how you think you should handle this situation? I know we've come across this ourselves, so I was kind of hoping some members of my team back there might be willing to give some suggestions. Anybody? Go ahead.
It is me. So I would just politely say to Anna that just as I am obligated to uphold a certain standard in terms of confidentiality and privacy with you, I am held to that same standard with other clients, including Tiffany. So I'm not at liberty to discuss our sessions, but Tiff is your friend, so you guys are free to talk. Is that a problem? Oh, well, I'm going to give it to you now.
I'm sorry.
Yeah.
I was just saying, and I was trying to think of how to answer that, because you can't even acknowledge that you know that person by HIPAA law, is my understanding of it. So I'm trying to think of what I would say.
Go ahead. We have some suggestions.
Somebody give me some ideas. We have people who transition together who know each other, and we know that they know each other because they see each other when they come in for day hospital treatments. So when they ask us questions then about the other one, we'll say, you need to talk to so-and-so about that. We'll say, you need to talk to that person and ask them those questions. and kind of divert it that way. But anyway.
Our line that we were taught, which is a really nice catch-all, is I can neither confirm nor deny that I work with that person. And then sometimes you can put a positive spin, like, but it sounds like you're connecting with a friend who has a similar condition as you, and I think that's a really positive thing, and I'm so glad that you guys are able to, spend time together or whatever.
I like that. Sounds like you're in law enforcement. Anybody else? Keely, do you have something else? Oh, go ahead, Ray.
I'm not going to claim to have a perfect answer for this, but we actually have patients who have the same father and different mothers. And and or our family members, maybe even cousins or something like that. And we just simply refer them back to your family members. You can talk to your family members, but again, that confirm or deny, we don't go into that detail.
Oh, wow.
I was just going to add that I would explore a little bit as to why she was asking, or where her questions are coming from. Oftentimes, there's things that she may want to know about, my work with another client, but really it's driven by some questions she has about her own care or our own relationship, or things like that. So my kind of standard is to deflect it back to the patient and say, tell me more about why you're asking, or tell me more about your question. Is there other things you want to know? So.
I don't know. I think Ron might. Did you want to say something, Ron, before Tiffany, or no? Oh, wait, Tiffany wanted to say.
To create a diversion and bring it back to the attention of the patient or the client that's there, instead of having her to ask about someone else. Then I would just ask open-ended questions and discussion about them. Just put everything back on the other person.
I was just going to say that happens a lot in the inpatient setting, and we often will just encourage the person that they're asking about, if they're in the room, to give permission to release information.
To talk in front of them and things like that.
And get their permission so yeah, that's always an option as well.
Stephanie?
Thank you. I've had that situation where a patient knows another patient, and the patient said, oh, when I'm inpatient and the other person is inpatient, you can tell them I'm here. No, I can't. HIPAA says I can't do that. The law says I can't. I don't go into denying or confirming. I just tell them straight up. HIPAA says I cannot do that.
So I think we all get the general idea that this is sometimes challenging for us as providers. We realize that in some ways that patient's concern or their opinion is something that, of course, you can listen to but can't respond back to. And sometimes you realize that patient maybe is trying to get information about someone else. And so a lot of it comes down to always remembering the law, of course, and also your institution's framework on how they think that you should be responding to situations like that. We kind of touched on this a little bit yesterday, but we have 5 individuals now that are living in an apartment complex that the program has some input and support to. So a lot of times, Stephanie and Marla will go out to the apartments together. And so sometimes even those 2 patients can be together, and they probably have to make some quick decisions about how they're going to handle the conversations that are going on with those 2 patients between the 2 of them. So that, it's sometimes situations where you have to decide, okay, how do I handle this and make sure that I'm still protecting the rights of everyone that's there. But just don't forget, they're still going to call your name out in the waiting room.
I got one for you.
Yes, Dr. Smith.
I have 2 sets of siblings who like to come to clinic together. You can imagine what else they like to do. Share medications. And so it's been very, very touchy. Because I allow them to come to clinic together because they arrive together in the clinic at the same time, in the same car. It's convenient, it's efficient. I let them come in the room at the same time. They provide information about one another. During Joe's visit, Jim is telling me about Joe's care, and Joe's telling me about Jim's care. I completely discourage when they volunteer to me that they're sharing medication. I say, that is a crime. I didn't hear that. We're not going to talk about that.
It's tough. I mean, they live together, so that's, it's a challenging situation. So obviously we have certain information that we need to be careful about, especially in research projects. So protected health information is something when we are filling out consent forms, we have to make sure that we address the PHI issue in the consent forms, and particularly to make sure that we have at least received the internal review board's permission to be able to capture that information about that person and figure out how it could be appropriately shared, de-identified, do the things that are important to protect that person's privacy. I don't know in the healthcare system how much of that outside of what the providers see, because I'm not on that side of the avenue, to know if they have to have that same kind of approval, so to speak. But I do know that you have to be careful if you're not working with that patient, that you're not sharing that PHI information with somebody. So we all try to do our best to make sure that we're protecting the anonymity of the patients that we're serving. The notice of privacy practices, again, that's something that most of us are very familiar with. A clear written explanation of how VCU handles your privacy, and that you, of course, consent to that. And then the minimum necessary rule is any disclosure that must be limited to the information necessary to carry out the purpose of the disclosure. So there are times when there has to be some minor information that might have to be shared with someone else who may not have been directly involved in the care of that person to begin with, but due to changes in their circumstances, you may have to give that minimal information to another provider or caretaker just to make sure that they are doing what they need to do to take care of that patient. What we always try to say is get a release of information, even if it's from a parent to a child, a spouse to another spouse. Keep it in the file. That way you're always covered. Again, I talk a lot about our 18 to 25-year-old population, and we have parents who still, some parents even have older kids than that. But if the parent needs to get in contact because they're still helping to pick up medication or some of the other things that they're doing, have a release of information on file. It just makes it easier for you. That way you don't have to try to figure out what you can and cannot do. So we've tried to make that part of our practice. So this is information that is considered PHI information. Are most of you familiar with all of these different terms and what they mean, and agree that this is PHI information that you need to be careful about sharing? Okay. Patient right information, again, this is pretty self-explanatory. What can or cannot be shared, how the facility can use your PHI information. And this should all be spelled out most of the time in your HIPAA forms that you're signing. And then allowable disclosures and then non-routine disclosures. Of course, like I said yesterday, as mandated reporters, you do have to report abuse or neglect. It's not a comfortable thing. You don't even have to give your name, although I would encourage you to do so as a professional because it is supposed to remain confidential. And then, of course, if there's other legal issues such as rape, domestic violence, the things that we've also been speaking about. So the CFR Part 2 Act came into place to deal with patients who are dealing with substance abuse treatment. This is really significant for the lifelong care of somebody. Just like Dr. Smith was saying yesterday, when you put a mental health diagnosis in someone's chart, that is something that sticks with that chart probably for the most part of their life. So you'll see psychiatry notes and psychology notes and social worker notes that provide clinical care. They're much more protected than even general notes to all of us. So like, for example, I cannot go in I don't have access approval to go in and read a psychiatric note. Now, some people here do, but I do not. And that is because I don't really have the need or the necessity to go in and see what that patient's treatment is. The same thing holds true for substance abuse care. You know, people that seek substance abuse care, they want that to be private unless they choose to share that with you. And so, again, that is something that can follow them from employer to employer, cause them to not get a job. Sometimes they end up having a God forbid, you know, a felony charge or a misdemeanor charge for something along those lines. So it's really important to try to maintain that confidentiality if somebody is seeking substance abuse treatment. So again, you know, this is just kind of referring what I just got done talking about, and it's just, again, something we really just need to be very cautious about. I don't know how many of you actually does anybody here actually deal with substance abuse patients directly? Okay. So was there anything else you'd like to share about that?
Well, I know that there are rights. I don't know all the laws that protect, but I do know that they can't be discriminated against, and that it's not something I would normally share with other professionals unless there is a direct need to know they're actually providing care.
Right.
That also, I mean, I know just putting in the note, concern for substance use disorder, just the concern for, once you put that in the note, then it changes, everybody's perspective about that person. So, yeah, you definitely don't want to do that unless it's really indicated.
Any other comments about that? Yes.
I know on our, a lot of times the patients that I work with, they may have like a significant other, mother, grandparent, or something like that wants to be involved with their care, and I always provide the authorization to release information form, and they actually have that exception for substance abuse where you want to release all this information with the exception of anything related to substance abuse.
Right.
So, and even if somebody is not currently being treated or there's no information in there, they have that moving forward as well, because if something does come about, then they know that this individual has access to get information, but it's going to exclude that portion of it.
Yes. Okay, so again, we talked about this yesterday and a little bit more just recently. Mandated reporters, licensed clinical social workers, anybody that's working in the healthcare profession, nurses, doctors, must report child abuse and neglect. If you believe somebody is suicidal or homicidal, you need to report that. That is just something that I think my colleague over here could probably help out a little bit more, but it's the only time when you really don't need to have the permission of a patient. A lot of times people in practice might say, you're sharing something with me and I'm concerned for your health and I'm going to have to let you know that I need to report that if they feel that that's appropriate. But that is the only time you do not have to have a person's permission to do that. And of course, if somebody says that their life is in danger, that's especially from a domestic violence situation, and that is always a very challenging thing for anybody in the professional world, is when do you actually make that step to make a report? And, I hate to say it, but when I was in child welfare, I was telling you my stories before, these are some of the things when there was divorces going on, people would use this quite a bit. And so, you had to go out and you had to investigate everything. I think it's a little bit different in Virginia because we made a referral to somebody, to CPS on someone a couple months ago. We thought our case was pretty good when we submitted the information. We had documentation. This patient had had psychiatric issues. There was small children in the home, and they chose not to go out and investigate that case. Where I worked, we went out on any referral that came in. So sometimes you went out there and you had to hear the divorce stories and you knew maybe not there was something to this. And those were the most challenging cases to investigate because you always didn't know who to believe. Everybody had their story. They all seemed genuine. So the Family Educational Rights and Privacy Act is a law that protects the privacy of student education records and personally identifiable information from education records. This is really important probably for those of you who have children who have 504 plans or IEP plans. Somebody does not have the right to disclose that information about your child without your permission. That's just something for you to know. I don't know if there's any comments anybody wants to share about experiences they've had with that, but I think that's pretty clear cut and dry. Again, these are your rights as a parent. Again, I don't know if we really need to go over this too much because those of you who have children that are minors, you're probably living this every day. Is there any questions that you have about your rights as parents? So again, we talked about this in the beginning. It's really a necessary thing for you to build a relationship with someone for them to trust you. And I think Taylor's situation yesterday that she explained was probably the most challenging. And I don't know for any other of the clinical social workers here in the room. I believe that that role that you have is probably more difficult than it is for a navigator or maybe somebody else who's not working in the clinical capacity because of the fact that there's so much of that issue about trust and sharing feelings and disclosing something and making sure that that person is going to be there to actually help you and not take that information and, you know, tell it to someone else. So it's really important in any relationship to have somebody trust you. And I guess we can probably continue to reemphasize this numerous times through this presentation, but I think you kind of get the point. It's ethically responsible of you as a professional to do that. It's morally responsible for you to do that just because you would not want somebody to violate your trust. And again, you know, how much is trust? You know, again, we could keep going over this. So it's in your manual. So in reviewing our objectives, I wanted to kind of give you a little bit of a quiz. List up here on this list, out of the 4 reasons we're having you maintain confidentiality, which one of those does not fit? What do you think? It seems the most reasonable, but I'll be honest with you, I think sometimes that last one also comes into play. But, you know, I think depending on where you work, probably the first 3 are the most important for you to follow. But, you know, if you have a navigator program and you're housed within an agency, you do need to follow their policies and procedures. Oh, wait, that's not correct. So the next exercise I wanted to do was help, if we had some time, maybe in your table, I know some of you have more people than others, I wanted you to just take some of these key points here and try to develop a confidentiality script that you might use in working with your patients. So let's take about 5 or 10 minutes. Maybe you could use the back of the paper that we already used. Maybe you could have one lead person that might want to be the person who comes up and kind of tells us what your thoughts were. There's no right or wrong answer, just kind of giving you some opportunity to develop how you would want to present a confidentiality statement to a patient.
Second sound,
Okay, did you guys all have some time to put some pen to paper? Y'all still writing?
Almost done.
Okay, a couple more minutes or a couple more seconds. Okay, let's go ahead. Is there a table that's done? Let's start with a table that might be done. You're done? Okay. Here we go. Oh, never mind. We're starting back here first. Hold on. Okay. Everybody, let's just take a listen and see what they came up with, and we'll have some conversation.
Oh, I'm up first?
Go ahead.
Oh, okay.
Are we ready?
Yep.
Okay, so this is our confidentiality script that we came up with, talking to a patient. Confidentiality is a way to protect your personal information and is governed by the law. For example, your name, date of birth, social security number, and any information discussed between you and your provider, any treatment received, are some examples. Under these confidentiality laws, you have rights. For example, requesting to review your records, rights to restrict your information, or in some cases, modify or remove information from your record. While, what's that word? Okay. While you are entitled to these rights, I must inform you that I must share any type of information that I feel could be harmful to yourself or others. So please read this form carefully, and if there are any questions, please ask me before signing.
I like that a lot, and let me tell you one of the things that I think is really important too. I think it's important for you, if you're doing something like this, to not assume that somebody can read that form And if you could keep it short and simple, and as long as you're not insulting somebody's intelligence, it's probably best if you try to read those things to them than assume that they understand what they're signing. Go ahead. Nobody at that table wants to give us their script?
We did a different exercise.
Okay, well, let's hear what it is. Always a troublemaker. No, let's hear what you did, seriously. Go right ahead. You probably did the next one, I'm suspecting.
So we were just laughing because so in me and Alicia's job, we talk about confidentiality every day. But it's very different than what most people would do because we are, she's a social worker, I'm a psychologist. So we keep confidentiality a little bit different. And we work with kids, so it's even more complex. So we didn't go into any of that. We actually had a conversation about different levels of confidentiality and where confidentiality can be maintained and where it cannot be maintained. And one thing that I talked about is in talking with families, I have to kind of alert them to certain places that confidentiality is not going to be maintained, like using social media and things like that, where they're not always, they're thinking, oh, well, I'm joining a group and this is for, other families with sickle cell, and they don't recognize that it might be a public group and it's not as private, and so having those conversations. And so we were just talking about different organizations and how to maintain confidentiality and where we can't guarantee confidentiality.
I think that's a great point. Like I said, this is a 7-year-old presentation, and so social media wasn't the big thing back then. So maybe the next time, adding some slides in there about what you just suggested would be really important, especially pertaining to any really children or adults. Sometimes adults think they're joining these private groups too, and it ends up being a public group. Anyone else?
My dad? This table?
Okay, don't be shy.
Obviously have something you want to share.
No. So the script we came up with, of course, you're going to introduce your name and your title, and then we would say, everything you tell me today will be confidential unless you harm yourself, others, or if there's an abuse or neglect case. Then you give them the forms and say, I will give you a chance to read them. If you have the inability to read them, that requests me to assist you, I can. And then you ask them if they have any other questions and have them to sign it.
So what do you think about that approach?
Yeah, in that element you're talking about, not to make the assumption that your client has.
Because someone with literacy issues have probably been dealing with those all of their life, and we have a lot of adults who really don't have the literacy skills even at a basic 6th to 8th grade level, and we assume that they do. So, we write these very complex forms and talk in ways, and they're like looking at you, nodding their head, and there's like deer in the headlights in there. So when you kind of give the patient, hey, listen, it's okay if you tell me you need some help, maybe they'll be more willing to say, I forgot my glasses today. Would you mind, and that's fine. You have to just take that and understand how that is. But thank you for putting that in there. That was very good. I appreciate that.
And I like the beginning when they identified who they were.
They identified who they were. She liked that. Yes.
I'm up, I guess. We also did a similar activity as the other group. We didn't write
now we have
anything
another
out,
one. Okay, nobody follows the rules, right?
We just talked about similar things of like what are the limits to confidentiality and being upfront with the patient about that and letting them know that, if you tell me you want thoughts of harming yourself or others or abuse, that those are things that I would have to break confidentiality for. And letting them know that before the session starts so that they have the choice as to what they're willing to say or not say and things like that. So that was more of our conversation.
So let me I hope you guys will show hands. How many feel confidentiality is a struggle in a professional capacity? Well, sometimes knowing when to maintain confidentiality, when not to maintain confidentiality, where to talk about things, where not to talk about things. Sometimes you have to catch yourself. I overheard something yesterday taking place here in the conference, and I was like, should not be taking place right here. So I think we're all guilty of that. Sometimes you forget where you're at or forget who you're speaking with. Yes?
I want to give an example because I'm human.
Of course. Thank you for admitting that.
I am human. I am not perfect yet by any means. And I'm not going to say I gossip a lot, but I enjoy gossip and I like to ear hustle a lot when I'm at work. That's just me. However, I do find myself sometimes overhearing conversations or working with a patient and then maybe talking to one of the providers like, oh my God, so-and-so, and that's not appropriate. And in this profession, I've learned to stop and think about what I'm gonna say before I say it. Because the human in me says, you're just talking, you're not hurting anyone, right? But then the other portion of me says, is it appropriate? You're at work, you're not hanging out with your friends, because I have this great rapport with my whole care team. So it's easy to get caught up in that, I'm at work and it's okay, because she's a provider. But that's not, it needs to be on a need to know basis, not just because I had this conversation and now I want to talk about it. So I literally do better at thinking before I speak now, just because of the environment I work in.
Right.
So we didn't write a statement either. We had more of a dialogue. But one of the things that we did pull out is to start the conversation with more of a teach back moment and ask about how do you understand confidentiality? What do you think confidentiality is? And then from there, then you can kind of fill in the gaps and then address some of the other issues. But I also just want to point out, I really like the fact that using real life examples of where they are maintaining confidentiality in their life, like that they have personal control over, and where they're not, particularly around social media.
So one of the things I like to bring to your attention, if any of you do research, I found this very important when we were running our program. Consent forms, especially now, they're like reading a mini Bible. And honest to God, sometimes I don't even understand what they say. So when we were having our consent form for our study, I kind of came up with like 8 key things in the consent form that if somebody didn't want to say they had literacy issues or maybe really didn't understand what they were signing, the person which was the research assistant at that time, was supposed to go back and kind of just say, okay, well, now that you've read and you've signed the consent form, let me just recap like some of the top things that I want to make sure you understood. And those are some other things that you might be able to do when you're speaking with a patient or a patient's family, especially if you suspect something and maybe they're just not willing to be forthright, or maybe they're not able to be forthright. Sometimes, you don't want to embarrass somebody. But some people just have different skill sets than we do. So I just kind of came up with a little cheat sheet, and I would just say, okay, I just want to make sure that, we checked all the boxes, and that way you kind of put somebody at ease. And then if they said, oh, I really didn't know that was what I was agreeing to, okay, that's good. I'm glad we brought that to your attention. Okay, so I was going to do one more, but I think it's good to move into the next segment, which is talking a lot about documentation that the patient navigators and the social workers do here at our department, so that maybe those are some things that you could take back with you. And if I recall correctly, Daniel, we could not upload those. So you're going to have to go look at your books while we're talking about that. And I believe if you flip through past our presentation, hopefully we're able to have you go over those. So some of this came about as a result of our study that we've been talking about intermittently, and then we kind of built on it over the last year and a half. And these are some forms that when Daniel was briefly talking about, like, we're trying to capture everything, we keep trying to revise these forms to make sure that these metrics that we're trying to get for our reporting processes capture just about everything that we think of. So even though today those forms might look like that, next time we go to do a metric review, we might go ahead and figure out there's something else that we're missing. Oh, and by the way, they're coming around to scan you back in for the next session. So the first form, did you guys find the forms, first of all, in the manual? I know it's probably like looking through, I think they're in the back. They're in the back, all the way towards the back of the manual. Yes. For you guys, it would be before the... And I apologize that these do not have numbers on them. That is one mistake that we did. It's the demographic and medical history form. And actually, let me grab my manual.
It's like 2 pages after the one we just did. This is the start.
Did everybody find it? Again, I apologize, there's no page numbers on here. Did everybody find the forms? Okay. So now, again, these are not things that you need to go back and do, but these are things that as we continue to progress through the program and we realize are identifying outcomes that we need to report back to leadership, these are some of the forms that have helped us come to that place. So the demographic and medical history form is very encompassed, and we try to only do this one time per patient, but we try to keep it updated. Now, I'm going to be really honest with you. We don't do a good job about it because we're so busy documenting everything else that when something new might come up on the demographic form, we don't necessarily think to go back and add it or update it. So that is something that we really need to work on as part of our team, but we also feel that these things are really significant. And let me tell you one of the key things that we found when we were doing our study. We could not remember what someone's genotype was. So every single time we would talk about somebody or we would team somebody or something was going on, unless you clearly knew that that person was a certain genotype, you used to have to keep going back into the records. Well, on the adult side of care, we were not as good about even documenting them in our adult records. So now over the last couple years, we've been doing the hemoglobin electrophoresis, and we've been trying to make sure that there are genotypes in each of the records of the patients, because obviously it makes a difference. So if you look at this demographic and medical history form, you'll see that there's transition information in there. We try to maintain an emergency contact, and if you have an emergency contact, try to get a release of information also to talk to that person. We try to keep the insurance information updated. Marla, I'm not to put you on the spot, but do we go in and update the insurance information on this form when we find that? So we are going in and updating that because that also is a big deal when you're trying to get prior authorizations for medications. Any kind of other health information that would be important. And what we started to do this year is for our transition kids that are coming over, Caitlin has actually gone over to the pediatric department and sat down with, I forget, maybe Jennifer, and we tried to fill out as much of this information as we could on our transition patients coming over so that we had a more accurate record of their past medical history. Yes.
And I think on a couple of people I want to learn from one another.
Sure. Where is she?
And then somebody I have a specific question.
Our North Carolina group is back there to the left, and some right here.
Tell us.
Where's the microphone?
I want to be sensitive. Tell us what you're required to do for funding for your community-based organization in this light. What are you required to keep? And then tell us what you actually keep in terms of this kind of information. Because I think that you're going to do what you're required to do, clearly. But you might choose to do more than that. This is a pretty thorough demographic form. Tell me in Virginia, tell me in North Carolina. I just want to know what's going on in the community.
Okay, then you said, but when you saw Red Cap, that was what when we had the grant a couple of years ago, Get Connected, we had to go into Red Cap to do our reporting. So it required all the demographic data, the genotype, whether they were checking hydroxyurea.
That was required.
That was required. There was a question on it, so we had to go back and ask the
It's work.
families whether or not this was, before we did not have that. We just didn't do that. But then this became more specific. We had to have that.
Did you choose
for home visits. They did not have computer systems in their homes to go in and complete our information. So it was okay for us to take a paper copy and then come back. Once they signed that copy with that information, then that was kept in a file in the office, but actually on the line, this information was put in by my CH staff.
And then, thank you. What about North Carolina? What do you guys require to do your funders, and then what do you actually do? If more than that, what do you actually do?
There's a bunch of us from North Carolina. We're all one agency in 7 locations.
I don't think your mic's on. Is it on? Oh. Oh.
It must, oh, okay. Thank you. We're very fortunate in North Carolina as far as the community-based organization. There's one community-based organization in 7 locations covering 22 counties. But I say that we're fortunate because this program was established with forethought from people who none are in this room. 50 years ago, they codified in law, in state law, that there must be a sickle cell program in North Carolina. And the way that it looks right now is there is a strategic arm. There's an administrative arm through Department of Health and Human Services. Then there are the tertiary care centers. There's some ECU people here. And there are also other, I think, 6 major medical centers. And then there are the community-based centers in 7 locations. And then there are state workers who do a lot of what some of our educator counselors at the community-based centers do. To answer the question, we are required by our Department of Health and Human Services to make sure that our confidentiality, I call it HIPAA-rized, we're all HIPAA-rized, we all had to go through the training, had to sign off on it. We have to have all the documentation. Fortunately, also, we work very closely with the medical centers, so we're very intricate in that whole process. And on top of that, we do fundraisers, and we do education sessions, and we work in the community, and we do churches, and we go to schools, and we do 504s, and we do IEPs, and et cetera, et cetera, et cetera. We're fortunate in that we're able to do that. Very challenging, especially when you start talking about documentation and history and so forth. You have a pot of money over here that says you have to do this in this database, and then you have a pot of money over here that says you have to do that in that database, and then we have NCDHHS telling us that we must do this, which is who we've been funded under for 50 years. So it's not a real quick and dirty answer. I don't know if my counterparts want.
Can I ask you, how many workers do you have around the state?
In my office, there's 4 of us. CDO, or you talk about
The whole.
technically we're all one program, but we're CDO.
So I'm located in Charlotte, North Carolina, and Marsha is in Goldsboro.
Yes.
Anita, Jacksonville. We have Greensboro. Yeah.
So you have quite a bit of people in different locations.
So just to kind of piggyback off of what Marsha was saying, we are also required to have degrees and certifications. We are required to, I actually wrote some stuff down, you guys were going through it. We've certified in motivational interviewing, PHQ-9, alcohol and substance abuse, smoking and tobacco use. SCDAA does have a CHW training. Some of the content that you guys have covered today, it's a grueling process. I actually have somebody on my team who's going through that now. We all are sickle cell health educated, certified. And everybody goes to Alabama So yeah, and then as far as the documentation is concerned, the state is very specific. I know REDCAP is still going on. Another thing that REDCAP does capture is that transition piece, whether the teen is still, were they plugged in, and make sure I'm saying this correctly, like, did they transition well? What's that question on REDCAP? Does anybody remember? So it's a transition piece, but the state does require us to, demographic information. They want us to capture, like there's 5 or 6 different forms that have been condensed over the years. I think when I initially started doing this, it was like 12, Marsha? It was a bunch of them, but they want, as a part of the assessment tool, and we provide education, genetic counseling, we have to do a pre and post test. I mean, there's just a bunch of different things. So I was saying this earlier, it's super duper intricate, and the sickle cell patients in North Carolina are super fortunate, that we're there. And even just with some of the things that IFFI's doing and just growing. I was there prior to Dr. IFFI getting there, and you just don't know what you don't know until you do know, right? Yeah. And so I remember in 2012 when one of the hospitals closed their adult clinic that they had once a month, the first Wednesday of every month from 8 to 12, and they closed it, and it was like for 2 years until IFFI came along. And then now you have this IFFI, and it's like, what were we doing prior to that? So,
yeah, we had talked at breakfast, and we were hoping to get a copy kind of your, rules and regulation type of, processes, because we're going to be going and having that conversation with somebody right below the governor's office, or governor's, position in October. So anything that we can have, because really, if you think about it, we have 2 patient navigators for the state of Virginia. I mean, that's basically what we're dealing with. We don't have anybody else in Tidewater. Judy's down there pounding the pavement. Northern Virginia, they don't have anybody, definitely out in the rural areas. And I was telling you that story of somebody who died from South Boston because we couldn't get proper treatment. By the time they realized it, they died in the ambulance coming down here. So, we really agree that, you guys, we knew when we went out to ECU for the grant, we didn't have to train you all. You knew how to do everything that, we knew how to do it probably better. But I do think it's fortunate that you've had that in place for 50 years. If we get something like that, it'll take us 50 years to probably get where we need to go. So it's very important to have that. So I appreciate your input.
I'd also like to just say, and I think everyone in this room would probably agree with me, it is a flagship program. North Carolina's program is a flagship program. It's an awesome program. It's wonderful. On the other hand, there is so much work to do, and our resources are so stretched. It's nearly impossible to do what needs to be done for this patient population the way it should be done.
I totally agree with you.
That's just my take on it. Even in North Carolina, we cover a very rural area. There's, in our office, not just, we all have, but in our particular office, it's myself, Anita, Tamika, and an administrative assistant, and our counties go out, about 3 hours? Yeah. So, give that some thought, as the powers that be, as we're looking at what we can better do to serve. Even in North Carolina, there's still a lot of work to be done.
So thank you very much. I mean, I think it would be really interesting to share what you all have, and again, especially for our upcoming preparations. We want to go into that meeting very prepared with a plan, not only to cover VCU, but to cover, Tidewater needs to get their program back up and running. We need to get some resources out to Northern Virginia, and we need to get resources out to the areas like Emporia and South Boston, and even Petersburg, that's 25 minutes down the road, but goodness Lord, we beg people not to go there if they have a sickle cell crisis. Oh, in the Eastern, yeah, we have somebody coming, I think this week, 3.5 hours one way just to get sickle cell care.
They feel like they are not a part of Virginia, but they are.
Right.
If I can say one last thing, I think what has been paramount over the past few years that I've seen in Charlotte, and I've come from Fayetteville as well, is just the attitude that Dr. Iffy has in regards to like everyone goes, everyone works, everyone supports sickle cell. And that's been absolutely paramount. I mean, so even when you consider like the medical centers, they have the triad, peds, adults, and the community-based organization. She doesn't leave anyone behind. And that's been super paramount to just be able to just help the population, really help the population that we serve.
And we also recognize that we need to do more for the community-based organizations. We need to get them some resources. It's hopefully all in the package, but you know, we want to be ready because we need, like you said, even with all the things that you have, you're still stretched thin. So we're even stretched thinner even with the things that we already have in place. And just to think 2-3 years ago, we didn't even have a tenth of this probably. So I just also want to go, you guys can look through these forms. We do everything in REDCap. We feel that that is really important to be able to extract data. So there's an at-home crisis plan you'll see in here that our social worker does with patients that they feel may be at risk. A behavioral health note. So remember I said we do not want to put a lot of documentation in our Cerner records about mental health, but we do document any key components that social worker is doing in REDCap just for our database. We do the GADS 7 scale. The one thing that I think we did, and I want to point out to you all, and maybe you even have some additions to this from North Carolina, is we felt there was a good do's and don'ts list that we should do with patients. We didn't want patients to think that we were their personal caregivers, nor did we want them to think that they had to do things for us. So I think you go through your notes a little bit here, you'll see a patient navigator do's and don'ts list. When we did the study, we actually reviewed this with them and had them sign off on it. And then if there was ever any questions about something that a navigator could or could not do for them, then they could easily defer them to myself. And then of course, I put out the fire. So I thought it was very resourceful. We actually don't use that as much now, but in looking back at it, I don't think it's a bad idea for us to go back and review that with our patient population just so they know expectations. You were saying you're trained in the PHQ-9, so that's of course something we have in here. And then the patient navigator contact form, anytime there's any type of connection with a patient or something in relation to a patient, they document in their notes. And the goal is to try to have those notes documented within 2 business days. So we kind of set that up as a metric. So the metric is going to be how quickly do you come in and do your documentation. I know Marla, she tries to come in and do hers the following morning after she does what she needs to do, as long as there's not some crisis blowing up. I believe Stephanie does try to do the same thing, and Taylor, our social worker, she tries to do her documentation pretty quickly too. So that is really how we track a lot of the time that they're spending out there, where they're spending their time, how they're connecting with patients. You know, we find that most of us know our patients don't keep cell phones very long, but they do respond to text messaging. So we even document, are you texting someone? Are you leaving them a message? How many times did you try to call them? Oh, you were out in the community? What exactly did you do while you were out there? Plus, this is something that we use to sell to the health system of the value of that particular position. Because they're just not familiar with thinking out of the box in an academic situation. Everything got to have the I's dotted and the T's crossed. I'm in a complaint right now with our risk management department about something I wanted to do with our adult transition group, and I'm getting squashed on it, but I'm going to continue to fight for it because you got to start thinking in 2019. You can't keep treating individuals who are having trouble with trust and building relationships and doing things all on the same metric scale. So I said one of these days I'm going to get fired because I'm always doing something I'm not supposed to be doing. There's a safety plan in here. Once again, that's something that's done by our clinical social worker. The Socrates is the substance abuse assessment that they do on patients. And our goal right now is at least to try to do it on all transition patients as they come over. So our goal is to now get a baseline on transition patients. We want to do the TIP RFT. And those that are in the PCORI study have to do it anyway. We want to do the PHQ-9, we want to do the Socrates, we want to do the GAD. We want to get a baseline score on patients because we're finding that when they're coming over from transition, they were great in pediatrics, and then they come over in transition, and all of a sudden we're having all these problems and we don't have a baseline. So that's something new that we're putting into place. So if you just go through here, these are just some of the different things. We do actually have a transition form that the pediatric department does try to have completed when they come over, and that's been relatively new, I think this year, maybe last year. So again, we're trying to have that full-blown, correspondence between the group. Yes, Marla? Oh, I don't know if that's in here. So the other thing that we wanted to start tracking, and I don't think it's in this book, is that the high utilizing group that Marla, I think, was speaking about yesterday, I'm asking that at least they maintain a quarterly contact with those who don't necessarily need it. So we have some patients' costs that are high because they're on apheresis, and they may not even know that we exist as far as the program that we have. So I just ask if they could at least make a face-to-face with them, maybe at a doctor's appointment or something. So every quarter, they're now starting to go in and track that they're doing that. It's just easier for them to go on another form. We just recently started that, so that might be why that's not in here. But you'll go through here, you'll see the post-hospital discharge form. That is something that we just initiated, that we wanted to try to track readmissions. If somebody comes back within 30 days, we're trying to figure out why they're coming back. We want to see if there's some way to prevent it when they're discharged. So now we do a follow-up plan. If they're on that high utilizing list, they are supposed to make a community contact with that patient within 14 days of discharge. If they're not on the high utilizing list, we do phone calls. Elena back there, our BSW intern, she's really good about following up with them and making sure that they have their appointments. Did they get their medications filled? Do they have transportation for their next appointment? Is there anything they want to tell her that we need to know? So these are just some things that we're putting in place. We're obviously open to more suggestions. So if there's anything else you think you might want to add to the group, please let us know. And then in the back of this is just some additional resources that we just use for Virginia or on a federal level, and we just put those in there for you as well. I know I went through a lot of stuff, and I know everybody's getting hungry. Is there any questions that you might have?
I assume it's fine for us to use these forms? Or
Sure.
how would you like us to use
You can use those as however you want. You could adjust them. You don't have to keep them the way they are. They're really just some good talking points about things that we have learned over the last couple years of what we're documenting. And like I said, even every time we go in with Daniel and do our metrics, we find out there's something else that we're missing, and we usually add something else to the form. That's how the quarterly form came up, is we really weren't able to track, well, are the navigators making that contact every quarter? So we just did a separate form. They're doing it, we just didn't have an easier way to track it. Yes, Marla? Yes, that's true. We did not put that in here. So there was a pilot that was done here in the institution about 2 or 3 years ago, where they had like an intern go in and ask patients if they came back within 30 days why they came back. And it was interesting because the patients came back for various reasons, but the providers thought they came back for different reasons. So we started tracking that. Again, it's not something that I think we're really doing a great job about, but it's something we need to continue to improve on, because sometimes why we think patients are coming back in has nothing to do with why they're actually back in the hospital. So that helps us to maybe change some of the processes we have in place, or maybe revise something else that we need to be doing. So again, even though we're 1.5 years into this medical home, there's still things that we're learning, and there's still things that we're changing. And if there's any suggestions that anybody in the group can offer to us, of course, we're open to that as well. Thank you, Marla. Any other questions? Yes.
Are all these documents flow sheets within the medical record system that you guys use? Or do you do
No. No.
And then
These are all done electronically. So Daniel sets up all of our red cap forms. I would advise that if you have the opportunity to do them electronically, it's easy, because then whoever your data person is could just export it. And it's really easy for you then to be able to track your data. Tomorrow afternoon, for those of you that are staying for the training, the last session we have, it will be Daniel talking about how he actually develops the all of the metrics that need to go into the reporting process. It's pretty intense. This is why we actually just put a full-time person into that position, because it's really a lot to ask somebody to maintain a database. And with all the different things that we're trying to track, we really need someone to stay on it. So I would recommend, if you can do this, to do it electronically. At RedCap, it's been around now for a while. Vanderbilt started it back in, 10, 15 years ago, at least. So it's an easy way for people to track. They have iPads. If they have laptops, you could go in, you could track it while you're actually out in the community. So those are things that kind of help you stay in touch of everything. Dr. Smith?
Do not be intimidated. I know there's some programs just getting started. There's some CBOs going, what the hell? Start small. Do what you can handle. Do what's important to you and your patients and your clients and what's going to get you to the next step in the organization's evolution. Work from there. These are all wonderful, but you got to pick something. Remember I told you there was blood on the floor? Now, later, latest. You got to do a now, later, latest for your organization to figure out what it is you can do now with the resources you have now, rather than talk about, oh, I got to go out and get funding so I can do everything. No. Start with what you have now. Do something. Get some information. Use the information both for internal improvement and to take it to funders and others who you need to impress. Don't let this overwhelm you.
Because remember, we've been doing this a while, even though the medical home's only been up a year and a half. Some of this stuff we've been doing for a while. And we've been fortunate enough now to have somebody help us, put some resources in there. So you need to start small. We will help you. That's another reason why we're here. Even though you might not be part of the Train the Trainer group and doing the follow-ups with us, by any means, if you have any questions, comments, concerns, anything you want to share, we're available to you. And, we don't want this to just stop after today, because we all want you to be successful. The patient's quality of life really kind of depends on that. So we don't want this to just stop today.
Yes, we do. How do you do it? That was good. It is so impressive.
We're going to do some more prizes.
What are you doing?
Well, we can do the whole wheel because everybody's back in the pool now.
Ah, I see.
Yeah.
Fake, make it fake game.
Fair game.
All right, go for it.
Everybody that's in the room got at least one prize, right? Did we play our little game before, but somebody baked it out?
All right. So this.
Oh, now see, it's working now.
Yeah, no, that was the one that I had fixed
For
before
today,
leaving.
right,
Yeah.
okay. We need to go back to the one that has all the peoples on it. We eliminated some people.
That's strange. There you go.
We're okay on time.
Yeah, we have 20 more minutes. No, I said we have like 20 more minutes.
Oh, yeah, I know, we're actually, Shirley went rolling through those documents. We're having this question answer.
Yeah, go for it. Wow, put it up.
While we pull up our prize, is there any comments, questions, or anything that's been discussed this morning? I kind of zipped through and we were right on time. Now we're good. Everybody getting tired? Ah, here it comes.
Oh, there you go.
What?
Cake or you want to take an
I just hit it. Let's go. Oh, yeah. Oh, no, I don't know. Camille Radford? You won? clap, clap. Let's do, we're going to do about 5, I think. 4 or 5. Get to pick from what's left. Oh, can y'all see?
No,
I can't.
I need to do this. Anita, is she here? Anita Douglas?
Oh, come on, Anita. I don't have my glasses on. That's part of my problem. I have my glasses on. I'll be able to do it. See, it moves. Leela Islam? I know you were here. Whoop. She left? She was here. Okay. You come pick. So we're...
I see. 1 second.
Okay.
1 second. I see.
We're about back to the old. Everybody's in the pool now again. Brianne, Latrice Peterson? No? What have we only done? 2, right?
Yeah, only 2.
2 successful. See how it pops? Donna Zills? Ah! Come on up. That's what, 3?
2.
Number 4. The lucky winner is Bailey. Oh, we did that early. Natarangela. Right, Bailey. Good for you. I murdered your name. Say it for me. Just say your last name.
Notarangela.
Notarangela. Oh, it's not as bad. It's pretty. Oh, I know. I like it. Okay, last one before lunch. Nakia Vaughn. We're redoing. You're back in the pool. Okay, I think that was it, wasn't it? Wasn't that 5? Yeah.
I wasn't counting.
We can do another one. Do another one. Hey, I feel generous. All right. Judith Davis? Judith still here? No? We'll do it again. Jaquia Turner? Ah, okay. That's you. All right, we have lunch scheduled. We're actually a few minutes ahead of ourselves, so we've got plenty of time to kind of cruise over to lunch. And then we will meet back right on time, which is, what is it? I think it's like 1:20. 1:15. So thank you. So be back in here at 1:15 and we will get our afternoon started. Now go enjoy lunch.